Hi, my name is Brian Vizik. I practice in pulmonary medicine for the Terry Riley Health Centers just outside of Boise, Idaho. And this video series is focusing on COPD. In this video, I want to talk about therapy, inhaler therapy, and advancement past inhalers. In order to get the latest updates for therapy, check out the GOLD guidelines. Those are updated annually, and they're meant for both the specialist and the generalist in COPD care. They're your best resource for the most up-to-date, evidence-based medicine for COPD. When it comes to COPD treatment, we have three major categories of medications. These three are the same for both asthma and COPD, but the way they're utilized in COPD is very different. The first category is the beta agonists. These are bronchodilators. We're very familiar. There's long and short-acting beta agonists. These are often the first therapy we'll use in COPD. Second category is the muscarinics. These are both short and long-acting, and they are in the category of bronchodilator. Now, they actually work a little different than albuterol. They don't really relax constriction. They actually prevent that constriction in the first place. So when used with a different bronchodilator like albuterol, they're especially effective. This LAMA category is one of the most important aspects of the GOLD guidelines, encouraging us to use a LAMA-LABA combination for most of our patients with COPD. The last category is the inhaled corticosteroids. This is the one we often start with asthma, but with COPD, it's only brought in for certain patients. We want to add an inhaled corticosteroid to their therapy when they have type 2 inflammation. That's that eosinophil number. When it's over 300, and remember that's on the patient's CBC, when it's over 300, type 2 inflammation is likely playing a role, and inhaled corticosteroids are more likely to have a bigger benefit than a negative. If those eosinophil counts are much below 100, then often an inhaled corticosteroid benefit is limited and the negatives outweigh the positives. When it comes to determining the inhaler type for a patient, we often have to check insurance because they may cover one over another. If you have a chance, however, talk to the patient about the inhaler you're choosing. Data shows that when we include the patient in that decision-making process, they're more likely to be compliant and more likely to use the inhaler appropriately. Think about manual dexterity. Can they actually press down? Do they have the strength to actuate an inhaler? Think about coordination. Can they inhale at the same time they actuate? What about inhalation capability? Are they able to inhale deep enough to get the medications where they belong? If not, consider using nebulized therapy. Now remember those three categories I mentioned? All three of those categories of medications now come in a nebulized option. So that may be something you need to talk to your COPD patient about. One more point about the type 2 inflammation. When we have patients that are on the appropriate inhaler but are still struggling, the GOLD guidelines give us a plan to escalate therapy. We can move on to newer medications called PDE3 and 4 inhibitors. There's also the use of chronic antibiotics like a macrolide, like azithromycin. And we also have this new category of biologic therapy for COPD. For those patients with type 2 inflammation, again, an eosinophil level over 300, a biologic may be the way to go. I think of type 2 inflammation as an opportunity to change the course of illness. When that's part of the patient presentation and we interfere with that, we shut down or slow down that type 2 inflammation, the outcome for patients can be amazing. One quick story, because I just had this patient come back. It was his 1-year anniversary on a biologic. When I had initially seen him, he was on a LAMA-LABA. I had added a corticosteroid because his eosinophils were quite high. He did well. He liked that inhaler, and for about 6 months he was doing pretty well, but he had 2 exacerbations in that 6 months. So we talked, decided we were going to add a biologic. I just saw him back for the 1-year anniversary, and I know it's just an N of 1, it's one patient, but he hasn't exacerbated since we started. And that's just one of the possibilities, and it's something to consider. When they're struggling, we do have new therapies that can change the outcome for COPD. Thanks for watching this video series on COPD. Be sure and check out the other AAPA videos available.